Welcome back to the deep dive. We're here to really get inside the strategic thinking behind some of the most complex areas in medicine and science.
That's the plan.
And today we are tackling orthopedic extremes. I mean, really challenging stuff. We're looking at surgeons dealing with life-threatening bone and soft tissue tumors.
Right, where microscopic precision is everything.
And then shifting to pediatrics, looking at correcting deformities that, well, shape a person's entire life. It's about getting access to that decision-making playbook.
Exactly. Our sources today, they really span this huge range. We've got material covering, the diagnostic precision needed for tumors, the really life-altering choices patients and surgeons face.
Big decisions?
Huge. And then the very intricate surgical side of things, especially with congenital issues and managing growth diseases in kids.
So our mission for you listening in is pretty clear. We want to distill that critical high-stakes calculus surgeons are doing in their heads. We're focusing hard on, diagnostic accuracy, managing the complications that will happen.
Oh, they happen.
And anticipating those long-term outcomes, which, as we'll see, can sometimes be really counterintuitive, both in cancer care and in pediatrics.
Okay, let's jump in. Starting with oncology, because as you said, that very first step, the biopsy, it just carries so much weight. Seems routine, maybe.
Yeah, you'd think, but the sources highlight this fundamental rule, almost alarming. The biopsy track itself is considered contaminated.
It's a fascinating level of foresight, isn't it? Before you even plan the main surgery, whether you use a tiny needle or make an open cut for the tissue.
Doesn't matter.
Doesn't matter. That entire path your instrument took, you have to assume it's now lined with tumor cells. It's like a controlled, localized seeding almost.
Wow. And the implication then is that track has to go.
Have to go. It must be excised en bloc. That means in one single piece along with the main tumor when you do the definitive surgery.
Which means if that initial biopsy is put in the wrong place.
Big trouble. You could contaminate a nerve, a major vessel, or cross into another muscle compartment. That could force a much larger resection than planned or even make limb salvage impossible. The biopsy is part of the cancer surgery planning.
So it dictates the incision type immediately.
Absolutely. Critical rule 1. Avoid transverse incisions, like cutting across the limb.
Why specifically transverse?
Because, think about excising that track later. To get the whole thing out, you'd need this massive, wide oval of skin and tissue going sideways.
Leaving a huge hole.
A huge hole, exactly. Making it incredibly difficult, maybe impossible, to close the wound after the main tumor resection without needing complex flaps or grafts. So incisions must be longitudinal, straight up and down the limb.
Okay, longitudinal makes sense for closure. What about the path under the skin?
Just as critical. The rule is stay within a single muscle compartment.
Ah, containment again.
It's all about containment. If your needle or blade crosses that fascial plane between major muscle groups, boom, you've potentially contaminated both.
Creates a wider area you have to resect later.
Much wider. Makes getting those clean, wide margins way harder. And, of course, you steer well clear of major nerves and vessels for the same reason. Don't accidentally involve something vital early on.
Okay, and there's a specific warning about something usually standard in limb surgery.
The tourniquet.
Yes, this is a huge point of difference. The tourniquet warning. In, say, a knee replacement, you might wrap the leg tightly with an elastic bandage, squeeze all the blood out, exsanguinate it before inflating the tourniquet. Bloodless field.
Standard stuff.
Standard stuff. But in tumor surgery, you can elevate the limb, let gravity drain some blood, but you never ever compress it.
Why not? What's the fear?
The fear, and it's backed by a lot of historical data, is that squeezing the limb could literally force tumor cells, which might be floating loosely in the veins near the tumor, into the main circulation.
Like squeezing toothpaste out of a tube. Kind of. You risk pushing those cells systemically, potentially seeding metastases faster. So just elevation, then inflate. It's a major shift from normal ortho practice, showing that unique containment thinking.
Right. That elevates the biopsy from just getting tissue to being the first strategic containment move. So you've got the tissue. How do you decide how to get it? Speed versus detail.
Exactly. It's a trade-off. We basically have 3 main ways. First, fine needle aspiration, FNA.
Quickest.
Quickest.
Yeah.
Just sucks up some cells. It can be pretty accurate, maybe up to 90% for just telling you if it's malignant. Cancer, yes or no.
Yeah.
But it gives you only cells, no tissue architecture. You can't tell the specific tumor type. You can't tell the grade, how aggressive it is. And that's essential for planning chemo or radiation. So FNA is okay for checking maybe a suspicious lymph node or confirming a known metastasis, but not great for a primary diagnosis.
So if you need to see how the cells are organized, the structure, you need more tissue.
You need more. That brings us to the core needle biopsy. This is kind of the workhorse now. Uses a bigger needle, gets a small cylinder of actual tissue.
So you get architecture.
You get architecture. Pathologists can see the layout. Studies show overall accuracy is pretty good, 84% to 98%. It's about 97% accurate for just malignant versus benign.
That sounds good.
It is good, but it's only around 81% accurate for the specific type and grade. That small sample size can still sometimes miss the most aggressive part of a big tumor, or you might not have quite enough tissue for extra tests like, genetic markers if needed.
Which leaves the most invasive option.
The open biopsy, a surgical procedure.
The gold standard, they say.
It is in terms of getting the most information. You get the largest piece of tissue, plenty for all the detailed pathology, cytogenetics, molecular stuff, least chance of sampling error, especially if the tumor looks different in different areas.
But the downside?
Highest risk of complications. Infection, bleeding, more tissue disruption, potentially violating more planes if not done perfectly, according to those rules we discussed. And this all ties into the frozen section rule.
Okay, explain the frozen section rule. This happens during the biopsy surgery itself.
Right, during the open biopsy or sometimes even with a core if there's enough tissue. The surgeon sends a piece immediately to the pathologist who does a rapid freeze and stain the frozen section. It takes maybe 15-20 minutes.
And what are they looking for?
They're looking for a clear answer now. If they see something straightforward, like clearly a giant cell tumor or definite metastatic cancer that's about to break the bone, something where the treatment is standard, then the surgeon might proceed with a definitive procedure like curettage or putting a rod in right then and there.
But if it's not clear?
That's the crucial part. If that frozen section shows anything atypical, any hint of a sarcoma, anything that looks high grade or unusual, the rule is stop.
Stop the surgery.
Stop the definitive part. Close the biopsy wound, wake the patient up, and wait. Wait for the final permanent pathology results, which takes several days. You absolutely do not proceed with a major resection based on an uncertain frozen section.
Why the mandatory pause?
Because if you guess wrong, if you do an inadequate surgery for what turns out to be a high-grade sarcoma, you've likely compromised the patient's chance for cure. You might leave tumor behind, make definitive resection harder later. That pause is non-negotiable for safety.
That level of caution really underscores the stakes.
Yeah.
And it flows right into the goal of the definitive surgery itself, getting the right margin. The language here, the margin terms, it's everything.
It really is. The margin defines success or failure in cancer surgery. It's the vocabulary. We break it down into 4 main types, based on where the surgeon's dissection plane passes relative to the tumor.
Okay, let's walk through them. Lowest level.
Lowest level is intralesional. The dissection, the cutting happens inside the tumor itself.
So you're cutting through cancer.
You're cutting through gross tumor. This is basically just debulking, removing some of the mass. It always leaves visible tumor behind.
When would you ever do that?
Only really in palliative situations, maybe to relieve pressure on a nerve when cure isn't possible. Or sometimes for a benign but symptomatic lesion like a lipoma, where getting it all out would mean sacrificing something critical and isn't necessary for cure.
Okay, moving one layer out.
That's marginal. Here, the dissection goes through the reactive zone around the tumor. This zone often forms a kind of pseudocapsule compressed normal tissue, inflammatory cells.
Is that good enough?
It's perfectly adequate for most truly benign tumors and even for some very low-grade malignancies where the risk of spread is minimal. But, and this is a critical but.
Here comes the nuance.
Here's the nuance. For high-grade cancers, like osteosarcoma or Ewing's, that pseudocapsule, it's often infiltrated with microscopic nests of tumor cells. Little satellites that have already jumped just outside the main mass.
Invisible to the surgeon.
Invisible. So if you only get a marginal margin on a high-grade tumor, you've almost certainly left microscopic disease behind. Local recurrence is highly likely unless you add adjuvant therapy, radiation, or chemo to kill those remnants.
Which logically leads to the goal for aggressive cancers.
Wide or radical margins. This means the surgeon cuts well outside the reactive zone through completely normal, healthy tissue, ideally leaving a cuff of several centimeters of normal tissue around the tumor.
That's the bullseye.
That is the goal. Our sources are crystal clear. Achieving a wide margin is the single most important technical factor influencing overall survival for patients with high-grade sarcomas. If you can't get that wide margin while saving the limb,
Then amputation is the only way to achieve it.
then amputation becomes the oncologically necessary choice to maximize survival. It's that fundamental.
That really sets the stage perfectly for part two. We're moving into the realm of multimodal treatments, systemic therapy, and these incredibly tough, life-altering choices. Let's start with how chemotherapy changed everything, using osteosarcoma as the classic example.
Yeah, the history here is stark. It tells you so much about these diseases.
Right.
Before the 1970s, when effective chemo protocols became routine, the standard treatment for osteosarcoma was immediate radical amputation. Get the whole tumor out, wide margin.
Sounds definitive.
You'd think. But even with that apparently complete local removal, the devastating finding was that 80% of those patients still died.
80% died of what?
Died of metastatic disease, usually in the lungs, within 5 years.
Wow. So the amputation wasn't curing most people.
Exactly. That horrific statistic was the key discovery. It proved that the vast majority, 80% of patients who walked in the door with what looked like localized osteosarcoma already had undetectable micrometastases elsewhere in their body at the time of diagnosis. Surgery alone, no matter how radical locally, was simply not enough.
And chemotherapy changed that number.
Dramatically. The routine use of modern multi-agent chemotherapy protocols, given both before and after surgery, it has pushed the 5-year survival rate for osteosarcoma up to around 70% now.
From 20% survival to 70%, that's huge.
It's a monumental difference. It proved the necessity of the multimodal approach. Surgery takes care of the local disease you can see and touch. Systemic therapy, the chemo, hunts down and kills the distant, invisible disease.
What about radiation? Does it play a big role in bone tumors?
Less so for the most common primary bone cancers like osteosarcoma and chondrosarcoma. They tend to be pretty radioresistant, meaning radiation doesn't kill them very effectively.
But there are exceptions.
Oh yes, important ones. The group often called small blue cell tumors, things like multiple myeloma, lymphoma affecting bone, and Ewing sarcoma. These are actually highly sensitive to radiation. It's often a key part of their treatment, sometimes the primary local treatment.
What else responds well?
Also, many cancers that metastasize to bone from elsewhere, like breast or prostate cancer. Radiation is very effective for controlling pain and preventing fractures from those metastases. But there's a key exception mentioned in the sources.
Which?
Renal cell carcinoma, kidney cancer, that spreads to bone. Those metastases tend to be quite radioresistant, unfortunately. So for most other bone tumors, surgery still offers the best chance for local control.
Okay, so you have chemo, maybe radiation, and surgery. Now comes that incredibly difficult decision point we hinted at. Limb salvage versus amputation. It's obviously packed with emotion, but how do clinicians actually frame the comparison?
Well, the clinical data, looking at long-term outcomes, is maybe surprising. The key finding, consistently across studies of sarcoma survivors, is that there's no significant difference between amputation and limb salvage when it comes to long-term psychological well-being or overall quality of life.
No difference. That seems hard to believe intuitively. Saving the limb must be better psychologically, right?
You'd think so, but the reality is more complex. Both paths have significant burdens and challenges that seem to, on average, balance out over a lifetime.
Okay, let's unpack that. What are the downsides, the morbidities of amputation?
Well, beyond the immediate surgical recovery, you have the risk of infection, wound healing problems. But the long-term issues are significant. Chronic pain in the residual limb is common. Then there's the very real and often distressing phenomena of phantom limb pain, feeling pain in the limb that isn't there.
The brain's still mapping it.
Exactly. And particularly in kids who are still growing, you can get bony overgrowth at the end of the amputated bone, requiring revision surgeries later on. Plus, the lifelong reliance on prosthetics, which need maintenance, refitting, and replacement.
Okay, so amputation isn't a one-and-done solution either. What about limb salvage? What are the costs there?
Limb salvage involves a much bigger, more complex initial surgery. Perioperative risks are higher, more blood loss, higher infection risk, higher risk of blood clots, DVT. But the long-term morbidity is where it really adds up.
How so?
A patient with a salvaged limb, especially one involving a large bone replacement or allograft, is almost guaranteed to need multiple future surgeries over their lifetime.
Guaranteed.
Why? Things wear out or fail. Endoprostheses can loosen over time. The bone around the implant can fracture a periprosthetic fracture. Allografts, the donor bones, can fracture from fatigue or the joint surface can collapse. And infection, even years later, is always a risk with implanted hardware.
So while you keep the limb visually, it's often a limb that requires ongoing surgical maintenance and might have functional limitations.
Precisely. The salvaged limb might not have normal strength or function. It might be prone to pain or instability. So you trade the psychological and physical challenges of amputation and prosthesis use for the ongoing surgical burden, complication risks, and potential functional limits of the salvaged limb. It truly balances out for many patients in the long run. High risk, high reward, requiring huge patient commitment.
Okay, if limb salvage is the chosen path, let's get into the reconstructive nuts and bolts. What are the main options after you've resected the tumor in the bone segment?
The most common method, according to our source authors, is endoprosthetic reconstruction, basically replacing the removed bone and joint with a large custom metal implant.
Like a hip or knee replacement, but much bigger.
Much bigger, yeah. Often modular, meaning built from different pieces to match the defect. Sometimes they even have expandable components for kids who are still growing, though those have their own issues.
What about using donor bone instead of metal?
That's using osteoarticular allografts. This is cadaver bone, carefully selected and prepared. The attraction is that you can potentially reattach the patient's own ligaments and tendons to the allograft, creating more biological reconstruction.
Sounds good. Downsides.
High complication rates, unfortunately. The junction between the patient's bone and the allograft might not heal non-union. The allograft itself can suffer fatigue fractures over time. If it includes a joint surface, that cartilage often breaks down quickly, leading to arthritis or articular collapse. And late infection is a higher risk than with metal implants.
So sometimes used temporarily?
Yeah, sometimes in a growing child, you might use an allograft to bridge a gap and preserve a nearby growth plate, planning to replace it with a metal endoprosthesis once they're skeletally mature.
Is there a way to combine the two, metal and donor bone?
Yes, the allograft prosthesis composite. You might use this if, after the tumor resection, there isn't enough healthy patient bone left to securely anchor a standard metal prosthesis stem.
Ah, so the allograft provides the needed length.
Exactly. You attach the allograft segment to the patient's remaining bone, and then you cement the prosthetic joint component into the allograft. It gives you length and allows for soft tissue reattachment to the allograft, while hopefully avoiding the joint collapse issues seen with pure osteoarticular allografts. Still complex, though.
Definitely complex, but maybe not as conceptually radical as the final salvage procedure we need to discuss. Rotation plasty, the Van Ness procedure. This one. It's hard to picture.
It is visually striking, no doubt, but it's a truly ingenious piece of biological engineering, used mainly for kids with tumors around the knee that require a very wide resection, making standard limb salvage impossible or highly dysfunctional.
Okay, break down the mechanics. What actually happens?
It's essentially 3 key steps. First, you resect the tumor, the knee joint, and the affected portions of the femur and tibia. Second, you bring the remaining lower leg segment, the tibia, fibula, foot, and ankle, up to meet the remaining femur. You fuse the tibia to the femur that's an arthrodesis.
Okay, so the knee is gone, tibia fused to femur, then the rotation.
Then the critical step. You rotate that entire distal segment, the lower leg and foot, by 180 degrees, so the heel ends up pointing forward and the toes point backward.
The foot is literally facing backward. Why? What's the functional payoff for such a radical change?
The payoff is converting the ankle joint into a functional knee joint. By rotating it 180 degrees, the ankle is now positioned roughly where the knee used to be.
And the ankle motion translates to knee motion.
Precisely. Ankle plantar flexion pointing the toes down now acts like knee extension, straightening the prosthetic lower leg that will be fitted below it. Ankle dorsiflexion pulling the foot up becomes knee flexion, bending the prosthesis.
That's incredible. The nerves and blood vessels just tolerate that twist.
They have to be handled incredibly carefully during the surgery, obviously. You need a good range of motion in that ankle joint beforehand, at least 90 degrees, and the hip needs to be stable. But functionally, it works surprisingly well. The gait is often reported as being more energy efficient, maybe 10% better than a standard above-knee amputation with a prosthesis.
But the appearance, that must be a huge factor.
It's undeniably the biggest challenge. The appearance of the backward-facing foot can be psychologically difficult for the patient and family, potentially leading to social adjustment issues. And there are physical complications, too.
Like what?
The main one is derotation. Over time, especially during growth, the surgically rotated foot can tend to drift back towards its original position. This happens in up to half of patients, sometimes requiring further surgery or bracing to maintain the 180-degree alignment. It demands immense commitment from everyone involved.
Wow. From microscopic margins to 180-degree rotations, the scope is just incredible. Okay, let's shift gears now, quite dramatically, into part 3. We're moving into the pediatric world, managing growth, correcting developmental issues. And here, time is often the critical factor, right?
Absolutely. In pediatric orthopedics, you're always working with and sometimes against growth. Understanding natural history and predicting the future is key. Let's start with developmental dysplasia of the hip, or DDH.
And the name itself is important, right? Developmental, not congenital.
Exactly. The sources emphasize this shift because the hip instability or even dislocation isn't always present right at birth. It can develop weeks or months after a baby passes their newborn hip check.
Which makes early diagnosis tricky. Newborn hips are mostly cartilage, hard to see on x-ray, so how do you screen?
Correct. Radiographs are basically useless under 6 months because the key structures, the femoral head, the socket, acetabulum, are cartilage and don't show up well. So in newborns, it's all about the physical exam. The Ortolani maneuver, feeling for a clunk as a dislocated hip, reduces the Barlow maneuver, trying to gently provoke instability. These are crucial.
What about later signs, if it's missed initially?
In older infants, say after 3-6 months, the most reliable sign is often limited abduction. One leg just won't spread out as wide as the other when changing a diaper. Asymmetric skin folds on the thighs can be a sign, but they're often present in normal hips too, so less reliable.
So if the exam is suspicious or for screening high-risk infants, you turn to imaging.
Yes, and early on, that means ultrasound. It can visualize the cartilage structures, but ultrasound is very observer-dependent. The quality of the scan and the interpretation really relies on the skill of the technician.
And timing matters for ultrasound, too.
Definitely. Findings before about 6 weeks of age can be iffy because many newborns have some normal temporary ligament laxity due to maternal hormones. So a slightly unstable hip might resolve on its own. After 6 weeks, ultrasound becomes more reliable, and as the bones start to ossify more, radiographs become the tool of choice.
And on radiographs, there are specific landmarks.
Yes, classic lines drawn on the X-ray. Perkins line, Hilgenreiner's line. These create quadrants. And the IHDI classification you mentioned earlier uses these quadrants to grade the severity based on where the top of the femur sits relative to the socket.
Right, the IHDI. So how does it help guide treatment decisions?
It gives an objective measure of how bad the subluxation or dislocation is. Is the femoral head just slightly out, grade 1 or 2, or is it way up high, completely out of socket, grade 3 or 4? A higher grade immediately tells you that simple measures are less likely to work, and you might need more involved treatment sooner.
Speaking of treatment, the standard for infants is the Pavlik harness, that soft brace. It's very successful, 85-95% rate. So when does it fail? What are the signs it's not working?
Failure usually means the hip isn't reducing properly into the socket, or it won't stay there. Key risk factors for failure are things like if the hip was already dislocated and irreducible on the initial exam, a negative Ortolani clunk, meaning severe soft tissue tightness.
Too tight for the harness to work.
Exactly. Or if both hips are dislocated. And critically, if treatment is delayed past about 7 weeks of age, the longer you wait, the more those soft tissues contract, making harness treatment less likely to succeed. If the harness hasn't worked after about 3 weeks of proper wear.
Time for Plan B?
Time for Plan B, which is usually a closed reduction under anesthesia, manually putting the hip back in place, followed by a rigid body cast called a spica cast. If closed reduction fails, then open surgery is needed to release the tight structures.
Okay, moving down the leg now to clubfoot, or talipes equinovarus, another complex, multi-part deformity.
Very complex. It's rigid, not flexible like some infant foot postures. Remember the acronym CAVE? Cavus, high arch, adduction, forefoot turned in, varus, heel turned in, and equinus, entire foot pointing down. All 4 components are present.
How do you measure the severity on x-ray, especially since casting is the main treatment?
You track specific angles on the radiographs taken between castings. The key ones are the talocalcaneal angle on the top-down AP view in a normal foot. The talus and calcaneus diverge, making an angle of 30-55 degrees. In a severe clubfoot, they become almost parallel, so that angle shrinks towards 0, or even becomes negative.
And the forefoot turning in.
That's measured by the angle between the talus and the first metatarsal bone. Again, in severe clubfoot, this angle decreases significantly as the forefoot adducts. Tracking these angles shows if the casting is successfully correcting the bony alignment.
The Ponseti method, that serial casting and manipulation, is the gold standard now, right?
Absolutely. It's revolutionized clubfoot treatment. It's highly effective, even for older kids or those with club feet associated with other syndromes, where surgery used to be the only option.
But there's a catch for long-term success.
Huge catch. Compliance with bracing. After the casting phase corrects the foot, The child has to wear a special brace, usually boots connected by a bar, for several years, mostly at night, to prevent recurrence.
Why is recurrence such a risk?
Because the underlying muscle imbalances that cause the clubfoot are still there. Without the brace holding the correction, those muscles will inevitably pull the foot back into the deformed CVE position. Compliance is everything.
If Ponseti fails, or for very late presentations, when do you have to resort to cutting bone doing osteotomies?
Usually if the deformity is still significant and rigid, especially in kids older than about 5 years. By that age, the bones are more formed, and soft tissue releases alone often aren't enough to get full correction. You need to surgically reshake the bones themselves with osteotomies to fix residual hindfoot varus or forefoot adduction that has become locked in.
Okay, shifting now from shake to size limb length discrepancy, LLD. Measuring this accurately seems critical for planning.
It's paramount. Being off by even a few millimeters in childhood can lead to centimeters of difference by adulthood. Old methods like tape measures or even single x-rays are prone to error.
So what's the state of the art now?
Technologies like the EOS imaging system are much better. It uses slot scanning technology to get very low radiation, simultaneous front and side view images of the entire lower limbs while the patient is standing. This gives incredibly accurate length and angular measurements in a functional, weight-bearing position.
And once you have the current discrepancy, you need to predict the future.
Exactly. Predicting the final difference at skeletal maturity is the key to timing interventions. That's where tools like the Moseley straight line graph come in.
How does that graph work?
It plots remaining growth against chronological age for the femur and tibia, based on large population data. You input the child's current leg length and their skeletal age, which might differ from their chronological age, and the graph predicts how much each leg will grow and therefore what the final discrepancy will be if you do nothing.
So it tells you when to intervene.
Precisely. It allows you to calculate the exact timing for a procedure like epiphysiodesis, stopping growth in the longer leg to make the legs end up equal, or within an acceptable difference when growth naturally stops. You might plan that surgery years in advance.
Okay, so what are the main surgical strategies? You mentioned epiphysiodesis.
Right, that's option one, epiphysiodesis. Surgically closing down part or all of the growth plate physis in the longer leg to slow its growth. It's relatively simple, low morbidity. Best for predicted discrepancies in the range of about 1.5 to 4 centimeters.
What if the predicted difference is bigger, or the patient is already done growing?
Then you might consider shortening the longer leg. This involves cutting out a segment of bone, usually from the femur or tibia, and fixing the ends together. It's accurate and safe, especially in older teens or adults.
Is one bone better to shorten than the other?
Our sources suggest femoral shortening is generally tolerated better than tibial shortening. The thigh has a much larger muscle envelope, which makes it easier to close the soft tissues without excessive tension after removing a bone segment. Tibial shortening can sometimes lead to compartment syndrome or skin closure issues if you take too much.
And the third option, the most complex one.
Lengthening the shorter leg. This is a major undertaking. Technically difficult, long duration, high complication rate, requires incredible patient and family commitment.
How does lengthening work?
You perform a controlled surgical break in the bone, usually a corticotomy that preserves the periosteum and blood supply. Then, using either an external fixator frame, like a Blizarov or Taylor spatial frame, or newer internal lengthening rods like the magnetic precise rod, you slowly distract or pull apart the bone segments, typically about 1 millimeter per day.
A new bone fills the gap.
Exactly. The slow, controlled distraction stimulates the body to form new bone, called regenerate bone, in the gap. But it's a long process, months of wearing the device, followed by consolidation. Complications like pin site infections, joint stiffness, nerve injury, and problems with the regenerate bone are common.
Definitely a major commitment. Let's look at a specific condition involving growth and angulation, Blount disease, or tibia vara. That's severe bowing of the upper shin bone.
Right, an angular deformity at the proximal tibia, often associated with internal rotation of the lower leg as well. Surgical correction usually involves cutting the bone, high tibial osteotomy.
Is there a particular technique highlighted for addressing both the bowing varus and the rotation?
Yes. The sources mention the elegance of the oblique osteotomy, often associated with Dr. Rabb. Instead of cutting straight across the tibia, the cut is made at an angle, maybe 45 degrees.
Why oblique?
Because of geometry. By making the cut oblique, rotating the lower tibial segment corrects both the varus angle in the frontal plane and the internal rotation in the transverse plane simultaneously, with just one rotational movement before fixing the bone. It's an efficient way to get multiplanar correction.
Clever. Finally, let's touch on fixing angular deformities caused by a partial growth arrest when only part of the growth plate stops working. This involves facile bar resection. Sounds delicate.
Extremely delicate. You have a situation where a bony bridge, a bar, has formed across a section of the growth plate, tethering it. The rest of the physis keeps growing, causing the bone to bend over time.
So you have to remove just the bar.
Exactly. The procedure involves carefully identifying that white, hard, sclerotic bony bridge under fluoroscopy, live X-ray. Then, using a small, high-speed dental-type burr, you meticulously grind away the bar until you see healthy, bluish facile cartilage on all sides of the defect.
You've removed the tether. What stops it from just reforming?
You have to fill the hole you created. The resulting cavity is packed with something to prevent bone from bridging across again. Usually, it's autogenous fat harvested from nearby subcutaneous tissue, or sometimes a small piece of silicone implant material.
The fat acts as a barrier.
It acts as an interpositional barrier. It prevents the growth plate from seeing the defect as a fracture that needs healing with bone. This allows the surrounding healthy physis to hopefully resume normal, untethered growth. Often, an osteotomy is done at the same time, just below the physis, to correct the angle that is already developed.
Okay, that brings us toward the end of this really wide-ranging deep dive. From, thinking about single contaminated cells in a biopsy tract to surgically rotating entire limbs and manipulating growth plates. The common thread seems to be this intense blend of high technical skill and incredibly strategic long-term planning.
It really is. So many of these decisions involve balancing what you do now against the predicted natural history of the conditions, especially in kids. A great example is Legg-Calvé-Perthes disease, LCP.
That's where the blood supply to the top of the femur, the femoral head, gets interrupted in childhood.
Right. The bone can collapse and deform while it heals. Treatment isn't just based on how bad it looks right now, but heavily on prognostic factors, predicting how it will likely end up based on certain signs.
And how do they predict that outcome in LCP?
A key tool is the lateral pillar classification. On an AP X-ray, you look at the outer third, the lateral pillar, of the femoral head epiphysis during the fragmentation stage.
What do the different groups mean?
Group A means the height of that lateral pillar is fully maintained. These kids generally do well, often regardless of treatment. Group C means the pillar has collapsed to less than 50% of its original height. These almost always have poor outcomes with significant deformity.
And Group B is the tricky one.
Group B is the middle ground, where the pillar height is maintained at 50% or more, but not fully. And here, age becomes critical.
How?
A younger child, say under 8, in Group B, often still has enough remaining growth and remodeling potential to do well, even with just observation or minimal treatment. But an older child, maybe 9 or 10, in Group B, their prognosis is much worse without intervention. They often need aggressive surgical containment procedures to keep the softening femoral head deeply seated in the socket to prevent severe flattening.
So the decision hinges on knowing when to trust the body's healing and when you have to intervene to change the long-term trajectory before growth ends.
Exactly. It's strategic foresight based on understanding natural history and growth potential.
So it really seems like this entire field we've explored is built on that kind of foresight. And often, as we've seen, getting the best long-term result relies on solutions that seem, well, counterintuitive at first glance.
Like, intentionally contaminating a biopsy tract so you can fully excise it later. Or delaying a major cancer surgery based on a frozen section result, or accepting the extreme cosmetic change of a rotationplasty to gain better lifelong function, or even knowing when not to operate aggressively in Perthes disease.
That's a great summary of the underlying theme.
Which brings us to our final provocative thought for you, the listener. We've seen today that in musculoskeletal pathology, achieving the best outcome decades down the line sometimes means embracing a method that seems counterproductive, or involves significant short-term difficulty, risk, or even a step backward cosmetically. So the question to ponder is, what other critical systems in your life, maybe financial planning, career development, personal relationships, even societal challenges, operate on a similar principle? Where might accepting a difficult, counterintuitive, or high-cost short-term measure be the necessary path to securing the best, most stable, and functional long-term result?
That's definitely something to think about. Thank you for joining us on this deep dive into the strategic world of orthopedic extremes. We'll see you next time.